Okay, let's unpack this. Today we're doing a deep dive into something uh, really challenging in clinical management.
It's a tough one.
We're talking about carcinoma of the stomach, but specifically when it presents with gastric outlet obstruction. You
Yeah.
might hear it called GO.
Right.
And this isn't just, a standard cancer diagnosis. It's it's a medical emergency that's literally sitting on top of an aggressive cancer. The patient's whole system is compromised because of a physical blockage.
That's a great way to put it because when you see gastric cancer with GO, it immediately tells you this is a locally advanced malignancy.
This isn't an early find.
Not at all. The tumor has grown to the point where it's acting like, well, like a physical cork in a model.
And it's all about location, location, location,
Yeah.
right? We're talking about the very exit of the stomach.
Precisely. The obstruction almost always happens in what we call the antropyloric region.
The pylorus being that muscular ring that lets food out.
Exactly. That ring, or just past it in the first part of the small intestine. And because of that location and just the sheer bulk of the tumor needed to block it, it's a huge signpost for advanced local spread. We're usually talking T3 or T4 disease.
So a pretty advanced too.
Very advanced primary tumor, yeah. And that physical problem, the blockage, has to be dealt with before you can even really start talking about curative surgery.
And, while gastric cancer itself might not be the most common cancer people hear about, this specific complication, GOO, is common enough that there have to be really standardized protocols.
Oh, absolutely. The data suggests that somewhere between 10 and 20% of all gastric cancer patients will present this way. So if you're a clinician in this field, you absolutely have to master this management sequence.
And the patient is often in a pretty bad state when they come in.
They're in an immediate metabolic crisis on top of having locally advanced cancer. It's a double whammy.
So that's our mission for this deep dive. We're going to walk you through the entire modern multimodal management plan for GO. We'll start with how to stabilize the patient, which is priority one.
It has to be.
Then we'll move into the really rigorous staging that decides everything. And finally, we'll cover the specific protocols, both when you're aiming for a cure and when, palliation is the goal. This sequence is just non-negotiable.
And understanding that sequence is key because in the immediate short term, that metabolic crisis caused by the blockage, it's actually a bigger threat to the patient's life than the cancer itself. We really need to break down the mechanics of the obstruction to understand why the treatment is so intense.
All right, so let's transition from the what to the how. We know the tumor is blocking the exit, but
Yeah.
how does it physically do that? Why is this blockage so total?
Well, the main driver, of course, is what we call progressive tumor infiltration. We're talking about an invasive cancer that's burrowed deep into the muscular walls of the stomach.
And I get the sense it's not just a lump growing into the stomach. It's how it grows around it that really matters.
That is the critical distinction. It's predominantly what we call circumferential growth.
Right.
So if you picture a garden hose, the tumor doesn't just grow like a mushroom inside it.
Right.
It grows completely around the circumference of the hose, thickening the wall and just squeezing that central opening shut. As it grows, the space for food to get through just shrinks to nothing.
And here's where it gets really interesting, because the tumor is the main problem, but the body's own reaction actually makes everything so much worse.
Yes. The secondary factors are huge. When you have this malignant infiltration, the surrounding tissue it reacts.
How so?
First, you get this intense local edema, which is just swelling. Fluid floods into the tissue right around the tumor, and that swelling can rapidly close off what little space was left. It's like a flash flood in a narrow tunnel.
So that's the acute problem. But there's a more chronic hardening process happening too, isn't there?
Exactly. This is maybe the most insidious part. It's the body's attempt to repair itself, which backfires. It's called a desmoplastic reaction.
Which is what exactly?
The cancer cells basically trick the surrounding tissue into churning out massive amounts of collagen and dense, stiff connective tissue. It's essentially scar tissue.
And scar tissue doesn't stretch.
It doesn't stretch, it doesn't move. It turns the normally flexible muscular stomach wall into this rigid, unyielding pipe. It's rock hard.
So you've got the tumor mass, the acute swelling, and this chronic, rigid scar tissue all working together to create a wall.
An impenetrable wall. And we should probably mention while we're on it, a really severe subtype called Linitis plastica.
All right.
It's less common, but it's a diffuse cancer that spreads all through the stomach wall, not just in one spot. It creates this classic leather bottle stomach. The whole thing becomes thick and rigid, which makes the obstruction even worse and almost impossible to treat non-surgically.
Given that kind of blockage, The symptoms must be incredibly dramatic. Let's walk through what the patient experiences, starting with the most, I guess, visceral sign.
Yeah, the clinical picture is pretty stark. It's all about the failure of the stomach to empty. And the classic, most striking symptom is non-bilious projectile vomiting.
Let's break that down. Non-bilious, because the blockage is happening before the bile duct enters the intestine.
That's the geographical clue right there. The obstruction is before the ampulla of Vater, so the vomit is just pure stomach contents, acid, saliva, and whatever food is in there. No yellow or green bile.
And the projectile part.
That's just physics. The stomach is a powerful muscle, and it's contracting as hard as it can against a total blockage. The pressure builds up and up until it has to be released, and it comes out with incredible force.
And the contents of the vomit. That also tells a story.
It really does. Patients will often say they're vomiting food they ate yesterday, or even the day before. That's the stale food sign, and it's a hallmark of just how chronic this retention has become.
Beyond the vomiting, what's daily life like for these patients? It must be miserable.
It is. Because the stomach is always full, even a few bites of food are just intolerable. This leads to something we call early satiety. They feel overwhelmingly full after a tiny amount of food.
And that fullness just stays.
It's a persistent postprandial fullness, yes. And systemically, the consequences are devastating. You see profound, significant weight loss and severe anorexia because the very act of eating is now associated with pain and vomiting.
And what about actual pain from the tumor?
They definitely experience epigastric pain, but often it's the mechanical symptoms, the fullness and the vomiting that really dominate the picture at first. Later on, though, especially if the tumor starts to ulcerate, we start looking for signs of bleeding.
Like what?
Things like hematemesis, which is bright red blood in the vomit, or melena, which is that dark, tarry stool from digested blood.
Okay, now let's move to the physical exam.
Yeah.
If you're the clinician and you're examining this patient, what are the telltale signs you're looking for?
There are two really classic physical signs. First, in a patient who has lost a lot of weight, you might actually witness visible gastric peristalsis.
You can see the stomach trying to work.
You can literally see the muscles contracting in waves, moving from the left side of the abdomen over to the right. It's the stomach desperately trying to push its contents past that blockage. It's a really striking thing to see.
A visible struggle. And what's a sign you can hear?
That would be the succussion splash. If you gently rock the patient from side to side while listening with a stethoscope over the stomach, you hear this sloshing sound.
Because it's full of fluid.
It's full of retained fluid that hasn't emptied hours after they've last eaten or had anything to drink. It's a definitive sign of stasis.
And beyond these local signs, I imagine the patient's whole body is showing the strain.
Oh, absolutely. The systemic signs are obvious. You'll see clear signs of dehydration, dry mouth, sunken eyes. And in advanced disease, you have to be vigilant for signs of metastatic spread.
What are those classic signs?
Well, you might feel a palpable epigastric mass, but the real ominous signs are things like a fixed, hard vertose node in the collarbone area.
The supraclavicular fossa.
Right, or a Sister Mary Joseph nodule, which is a metastasis right at the umbilicus. Finding any of those, unfortunately, immediately tells you it's stage 5E disease.
Let's spend a good amount of time on the metabolic side of this, because you said it's the immediate life threat. This constant vomiting of pure stomach contents leads to a very specific, very dangerous chemical imbalance.
This is probably the single most important clinical detail for any learner to master. It's a profound chemical crisis because the patient is vomiting huge quantities of pure gastric juice.
Which is hydrochloric acid.
Hydrochloric acid, HCl. They are losing hydrogen ions, which are acid, and chloride ions. So the body is left with a relative excess of bicarbonate, which is a base. This leads to metabolic alkalosis. The blood pH literally starts to rise.
And the classic textbook triad is hypochloremic, hypokalemic metabolic alkalosis. So low chloride, low potassium, high pH. Why do they become low on potassium? That's not in the vomit, is it?
And that's the aha moment of this whole crisis. The primary problem is the loss of chloride. That's the hypochloremia. That loss of chloride severely messes up the kidney's ability to get rid of the excess bicarbonate.
So the kidney can't fix the high pH?
It can't. So in a desperate attempt to hold on to volume and sodium, the kidney starts making a trade. To reabsorb sodium, it has to excrete a positive ion to maintain electrical balance. So it starts dumping potassium and hydrogen ions into the urine.
I see. So the kidney's basically sacrificing its precious potassium stores to try and fix the pH and hold on to water.
Precisely. It's a futile attempt that creates a vicious cycle. The low potassium, the hypokalemia, is incredibly dangerous. It can cause muscle weakness, even in the diaphragm, and it can lead to fatal cardiac arrhythmias.
So this isn't just a lab finding, it's an emergency.
It's a critical emergency that has to be aggressively reversed with IV fluids, specifically saline, which is high in chloride, and massive amounts of potassium replacement before you can even think about doing surgery or starting chemo.
And what other chronic signs show up in the blood work?
You see all the classic signs of chronic illness. Anemia is almost universal, either from chronic inflammation or from a slow occult bleed from the tumor.
Iron deficiency.
Exactly. But maybe the single most important prognostic marker we look at is the albumin level, hypoalbuminemia,
Low protein in the blood. Why is that so important?
because it's a direct reflection of severe chronic malnutrition. A patient with a critically low albumin has no physiological reserve. They simply will not tolerate the stress of a major operation or the toxicity of chemotherapy. It's a major red flag.
So we've got this patient who's in a mechanical and a metabolic crisis. The clock is ticking. You have to figure out the path forward. And that all hinges on super accurate, super fast staging. Where do you start?
The sequence is everything here, and it always begins with an endoscopy. That is the undisputed gold standard for the first step.
Why endoscopy over, say, a CT scan first?
Because it does four critical things all at once. One, you get visual confirmation. You can see the tumor, see the blockage. Two, you get a biopsy. You need tissue to prove it's cancer.
Right, you need pathology.
You need pathology. Three, you can assess the exact extent of the obstruction. Can the scope get through? How tight is it? And four, it opens the door for an immediate therapeutic intervention.
You mean like putting in a stent right then and there?
Exactly. If the patient is clearly palliative and just needs immediate relief, you can sometimes place a stent during that initial endoscopy.
Okay, so you've got your tissue diagnosis. Now you have to map the disease. How do you find out if it's spread?
That is the job of the contrast-enhanced CT scan of the abdomen and pelvis, the CECT. This is your mandatory comprehensive staging tool. It's the first major filter for distant disease.
So if you see spots on the liver, it's game over for curative surgery.
If you see clear, undeniable distant metastasis, big lesions in the liver, in the lungs, obvious spread on the peritoneum, the conversation immediately changes. It becomes about palliation, and you've just saved that patient from a massive, unnecessary operation.
And what does the CT tell you about the local disease, the T and N stage?
Locally, it gives you a really good idea of how deep the tumor has gone, the T stage, and whether the lymph nodes look enlarged, the N stage. And the picture of GOO on a CT is just unmistakable. You see this massively dilated, ballooned out stomach that just abruptly stops at a narrow point.
Which is the tumor.
Which is the tumor. It's a classic image.
Okay, let's talk about what feels like a really crucial and maybe overlooked step, the staging laparoscopy. Even after a state-of-the-art CT scan, you're saying we still need to do keyhole surgery just to look inside. Why?
This is a huge point of evolution in gastric cancer care, and it's driven by hard data. The reason is simple. CT scans are terrible at seeing small volume disease on the surface of the peritoneum.
Lining of the abdomen.
Exactly. We call it occult peritoneal metastasis, little tiny seeds of cancer that the CT just can't resolve.
And why is missing that so catastrophic for the patient?
Because the whole point of a massive surgery like a gastrectomy is the hope for a cure and R0 resection. If you miss peritoneal mets, you put a patient through this huge high-risk operation only to find out later that the disease was already spread and incurable.
So you've subjected them to all that risk for no benefit.
For no benefit, and you've delayed them getting the correct palliative treatment. The yield of staging laparoscopy is just too high to skip it.
What is that yield? How often does it find something the CT missed?
The data is pretty consistent. Staging laparoscopy will find occult peritoneal mets in up to 30% of patients who are thought to be resectable based on their CT scan.
30%, that's a huge number.
It's massive. It's a game changer. If you find those mets, the patient is spared the big open surgery and goes straight to the palliative pathway.
And the procedure is more than just looking, right?
It is. We also do something called peritoneal cytology. We wash the abdominal cavity with saline and then send that fluid to the lab to be spun down and looked at under a microscope.
Looking for free-floating cancer cells.
Exactly. And even if the surgeon sees no visible nodules, if that cytology comes back positive, that alone classifies the disease as stage 4. It just adds another layer of accuracy.
So how does all of this fit into the official staging system, the AJCC-TNM system?
Well, GEO itself means you're dealing with at least a T3 or T4 tumor. So if the staging laparoscopy and CT are both negative for spread, that patient is probably stage 2 or stage 3 advanced, but still localized.
But if you find anything,
If you find anything, liver mets on the CT, peritoneal mets on the laparoscopy, or even just positive cytology, they are immediately upstaged to stage 4. And that classification is the fork in the road that dictates everything that follows.
okay, so we've gotten the patient through the crisis, we've stabilized their metabolism, and the staging has confirmed they're in that potentially curative group stage 2 or 3. Now we start the actual treatment plan, but let's just re-emphasize that initial stabilization.
It is the absolute foundation. You can't build the house without it.
What are the top priorities?
Priority 1, nasogastric decompression. You have to put an NG tube down to drain that massively distended stomach. It relieves the pain, it reduces the risk of them aspirating that fluid into their lungs, and it breaks that vomiting cycle.
Priority 2 is fixing the chemistry.
Correct. Immediate aggressive correction of that hypochloremic, hypokalemic metabolic alkalosis. We are flooding them with IV fluids, tons of chloride and potassium. You cannot safely put a patient with a sky-high pH through chemo or surgery.
And the third priority is the long game, nutrition. These patients are often wasted away. How do you build them back up?
Nutritional optimization is paramount, and it's often the hardest part. You always want to use the gut if you can. Enteral feeding is better than TPN through a vein,
But the stomach's blocked.
so you have to bypass it. This almost always means placing a jejunal feeding tube, a J tube.
A tube that goes directly into the small intestine past the blockage.
Exactly. And this nutritional buildup phase can take weeks. You're trying to get their albumin up, get their strength back. There's a direct correlation between better nutritional status going in and better outcomes coming out.
So once they're stable and nourished, we move to the definitive treatment. And the whole philosophy here has changed, hasn't it? It used to be surgery first.
It did. But now, the standard of care for resectable gastric cancer is neoadjuvant chemotherapy. Chemo before the knife.
Why that change? What's the thinking behind it?
It's based on overwhelming evidence from major clinical trials. There are a few key reasons. First, even in what looks like localized cancer, there can be tiny, invisible micrometastases already floating around the body.
So the chemo attacks those from day one.
Exactly. It's systemic insurance. Second, on a local level, it works incredibly well to downstage the tumor. It shrinks the main mass, it can clear up involved lymph nodes,
Making the surgeon's job easier.
it makes a borderline operable tumor into a much more clearly resectable one. And most importantly, it dramatically improves your chances of getting an R0 resection.
The holy grail, getting the entire tumor out with clean margins.
That's the single best predictor of a cure. And major trials, especially the FLOT4 trial, showed that this approach of giving chemo before and after surgery significantly improves overall survival compared to just doing surgery first.
So let's get specific. If there's one chemo regimen to know for this today, it's the FLOT regimen.
The FLOT regimen is the undisputed benchmark now. It replaced older protocols. It's an intensive 4-drug combination: 5-FU, leucovorin, oxaliplatin, and docetaxel.
That sounds pretty tough on the patient. How is it given?
It is tough. It's typically given as 8 total cycles, 4 cycles before surgery in the neoadjuvant phase, and then 4 more cycles after the surgery in the adjuvant phase. That intensity is why it works so well. It leads to a big jump in R0 resection rates, and that translates directly into more patients being cured.
So after those first 4 cycles, assuming the tumor has shrunk, it's time for the main event: radical gastrectomy. For these geotumors, which are usually at the bottom of the stomach, what's the typical operation?
Usually a distal gastrectomy is what's needed, removing the lower portion of the stomach. But the most critical part of the surgery, the part that's non-negotiable in expert centers, is the D2 lymphadenectomy.
The D2 dissection. Let's really drill down on this. Why is a D2 so important, and what does it actually involve?
D2 means extensive lymph node clearance. Historically, many surgeons in the West only did a D1 dissection, where they just took out the lymph nodes immediately next to the stomach.
Okay.
But massive experience from centers in Asia, where gastric cancer is much more common, proved that cancer cells often skip that first layer of nodes and jump to a second tier further away along the major blood vessels.
So a D2 dissection involves going after those second-tier nodes, which must make the surgery way more complex.
Way more complex. A D2 requires you to meticulously dissect around the major arteries that feed the upper abdomen, the celiac axis, the hepatic artery, the splenic artery. This is high-stakes real
I
estate.
can imagine.
It's technically very demanding, it takes longer, and yes, it has a higher initial risk of complications than a D1. But we accept that risk because the data is clear. It radically improves long-term survival by clearing out that hidden disease.
So that D1 versus D2 distinction really separates a standard operation from a true state-of-the-art curative surgery.
It really does.
After you've removed the tumor and cleared the nodes, you have to put the plumbing back together. How do you do that?
Right, you have to reestablish continuity. The two most common ways are a Billroth II or a Roux-en-Y reconstruction. The Roux-en-Y is generally preferred these days
Why is that?
because it uses a longer limb of the intestine to keep bile and pancreatic juices from refluxing back up into the stomach remnant or the esophagus. It leads to fewer long-term complications like chronic gastritis.
And we come full circle back to nutrition. After all that surgery, are the feeding tubes done?
Absolutely not. The immediate post-op period is brutal. These patients have had a massive operation, they've been through chemo, and they'll have trouble eating at first. So it's highly recommended to place a feeding jejunostomy tube during the operation itself.
So you have a guaranteed route for nutrition.
You have a safe, reliable way to provide nutritional support to get them through the recovery and strong enough for the second half of their chemotherapy. It's just crucial.
That was a fantastic breakdown of the curative path.
Mm.
But now we have to pivot to the tough reality, which is that a lot of these patients are found to be stage 3 and aren't candidates for that surgery.
That's right. For them, the goal shifts completely to palliation. The focus becomes quality of life, and number one on that list is restoring their ability to eat and drink.
And when we're talking about palliating the obstruction, it all seems to boil down to one critical question.
It does. It all hinges on the estimated life expectancy of the patient. How long do we think they're going to live? And that projection dictates which of our two main options we choose.
So let's start with the quickest fix, endoscopic stenting or CMs. Who is the right patient for a stent?
A self-expanding metallic stent is the preferred option for patients with a clearly short life expectancy. Generally, we're talking about a prognosis of less than 3 to 6 months.
And why is it better for that group?
It's all about speed and being minimally invasive. You can place a stent in under an hour with just sedation. It offers incredibly rapid symptom relief. The patient can often be eating again within a day. When time is precious, avoiding a week of recovery from a big operation is everything.
But stents aren't a permanent solution, are they? What are their downsides?
Their main limitation is durability. Over time, they can fail. The tumor can grow through the mesh of the stent, or it can grow over the ends. The stent can also migrate and move out of place. If a patient lives for a year, the chance they'll need another procedure to fix the stent is pretty high.
And that brings us to the more durable option, a surgical gastrojejunostomy, or GJ.
A GJ is the preferred option for patients who have a better prognosis, so an estimated life expectancy of more than 3 to 6 months.
And this is a true bypass operation.
It is. You're surgically creating a brand new, wide-open connection between the stomach and the small intestine, completely bypassing the tumor.
So the higher initial hit of surgery is justified by the fact that it's a much more permanent fix.
Exactly. A well-done surgical bypass is far less likely to reobstruct than a stent. If you think the patient has a year or more, investing in a permanent GJ gives them a much better long-term quality of life.
And has the surgery itself gotten less invasive?
It has, thankfully. The trend now in major centers is to do a laparoscopic gastrojejunostomy. Using keyhole techniques really reduces pain and speeds up recovery. It's about providing lower morbidity palliation.
Now, relieving the blockage is one thing, but you still have to treat the cancer that's spread.
Absolutely. For these metastatic patients who are still in decent shape, a good performance status palliative chemotherapy is still essential. The goal is to slow down the disease, control symptoms, and prolong life.
And for the patients who are just too frail for chemo.
For those patients, the focus shifts entirely to best supportive care, BSC. This is just expert symptom management, pain control, nausea control, nutrition, all aimed at maximizing comfort and dignity.
Lastly, what about radiotherapy? Does it have a role in shrinking the blockage?
It's a very limited role today. Trying to shrink a big, fibrotic, hard tumor mass with external radiation is really slow and often not very effective for relieving the obstruction itself. A stent or bypass is much faster.
So where would you use it selectively?
It's usually reserved for specific stubborn symptoms. The most common use is to stop a tumor from bleeding. Radiation is quite good at that. Or it can be used for targeted pain relief, especially if the tumor is invading a nerve or has spread to a bone.
We have covered so much ground here. Let's try and synthesize all of this and talk about the overall prognosis and then get to the key takeaways.
Well, the big picture reality is that the presence of GO by itself tells you you're dealing with advanced disease, T3 or T4. So these patients are automatically in a high-risk group. Their survival really depends on getting through that initial crisis and being a candidate for a curative R0 resection.
So what are the top factors that predict who's going to do well?
Number one, without a doubt, is resectability. Was the staging laparoscopy negative? If you find peritoneal disease, the prognosis is just irrevocably poor.
Okay.
Number two is their response to the chemotherapy. How much did that neoadjuvant FLOT regimen shrink the tumor? A great response suggests a more favorable biology. A poor response suggests a really aggressive cancer.
And then the surgical factors.
Right. What was the final nodal status? How many lymph nodes were positive after that D2 clearance? And of course, did the surgeon achieve a true R0 resection? Those are the huge surgical markers. And you can't forget the patient's baseline. Their nutritional status going in is a massive predictor of how well they'll tolerate the whole journey.
Okay, to wrap up this deep dive, let's consolidate this into the key non-negotiable updates, the essential takeaway list.
I'd say there are 5 pillars of modern GO management. First, the FLOT regimen is the standard perioperative chemotherapy. That's settled science.
Got it. FLOT.
Second, staging laparoscopy is mandatory. You just have to do it. It prevents futile, high morbidity surgery in a huge number of patients.
And for the palliative side?
Third, endoscopic stenting is the go-to for patients with a short expected survival, so less than 3 to 6 months. You prioritize rapid, minimally invasive relief.
And for the curative surgery itself?
Fourth, D2 lymphadenectomy is the standard of care in high-volume expert centers. You have to do an extensive lymph node clearance for the best chance of a cure.
And the fifth pillar that holds it all together?
Every single one of these complex decisions has to be made in a multidisciplinary tumor board. The surgeon, the oncologist, the radiologist, the pathologist, everyone needs to weigh in to map out the best possible sequence for each individual patient. It's too complex for any one person to decide alone.
What a journey. We started with the sheer physics of this blockage, the visible stomach contractions, that life-threatening metabolic alkalosis.
Right.
Then we followed the patient through these incredibly strict staging protocols, that mandatory laparoscopy, and detailed the curative path with FLOT chemo and D2 surgery. And finally, we landed on that strategic, life expectancy-based choice between a quick stent and a durable bypass.
I think the biggest takeaway isn't just the list of treatments, it's the sequence. It's the understanding that modern cancer care is all about a specific structured order of operations. You have to stabilize before you stage, and you have to stage perfectly before you commit to these massive curative treatments.
Which brings us to our final provocative thought for you to take away. We've spent a lot of time on that palliative decision point, that really difficult clinical guess about whether a patient has more or less than 3 to 6 months to live, which decides between a stent and a GJ.
A very tough call to make.
Right now, that's based on clinical factors, scans, how the patient looks. But with the explosion in precision medicine, how might future technologies, I'm thinking of things like circulating tumor DNA or deep genomic profiling of the tumor, how might that refine our ability to predict that life expectancy? And if we could get a dramatically more accurate molecular prediction, how quickly would that just completely disrupt the algorithm we use to choose between a stent and a bypass right now?
That's a fascinating question. It's about integrating biological precision into what has always been a very clinical, almost intuitive surgical decision. We could move from an educated guess to a genetically informed probability.
Something to think about. Thank you so much for joining us for the deep dive. We hope you feel thoroughly up to speed on the complexities of managing this very challenging disease. We'll catch you on the next dive.